Epilepsy, BIPAP, cerebral palsy, why 24/7 CCRN care or ICU nurses is non-negotiable. If you have a loved one with complex medical needs and you've ever wondered if it's truly possible to bring intensive care into your home, the answer is a resounding yes, but only with the right level of clinical expertise. Today, we're diving into a critical case study that powerfully demonstrates why critical care registered nurses, also known as CCRNs or ICU nurses, is non-negotiable for 24/7 care, especially when life-threatening conditions and disabilities are involved. The evidence is clear in the case of one of our clients, a participant with extreme medical complexity and disabilities whose care requirements exceed by far the capacity of general registered nurses, let alone traditional support workers or disability support workers. The client's clinical picture includes a devastating or almost catastrophic combination of, dystonic quadriplegic cerebral palsy, but also refractory epilepsy, dysphagia, and hypercapnic respiratory failure with central sleep apnea. The compounding nature of these conditions significantly elevate the risk of acute medical deterioration as part of the disability, making continuous monitoring and expert clinical intervention essential day and night. The core clinical responsibility in this client's care cannot be safely or legally delegated to a general registered nurse, let alone to a support worker model, without compromising the client's safety and increasing the risk of death for the client. Here are the 4 non-negotiable reasons why this particular client requires 24/7 critical care registered nurses at home, which is basically intensive care at home. Number 1, life-threatening airway and respiratory management. The client's hypercapnic respiratory failure, which is also known as type 2 respiratory failure, and central sleep apnea necessitate BiPAP ventilation support overnight and during naps during the day. This essential intervention, however, also predisposes the client to significant aspiration risk, but also a support worker or even a general registered nurse without ICU experience wouldn't know when to initiate BiPAP, even how long to keep it on, and what are the complications of BiPAP that need to be managed and prevented. So number 1, there would be aspiration risk and dysphagia. The client has oropharyngeal dysphagia, resulting in a high risk of direct aspiration, which can lead to aspiration pneumonia and high mortality rates. The client is fully dependent on assistance for enteral feeding and medication administration. Next, deep suctioning. The client is unable to remove the BiPAP mask or call for help in the event of vomiting or copious secretions, further compromising the airway. The client routinely requires nasopharyngeal and oropharyngeal suctioning every 5 to 90 minutes while awake, and often during sleep, to prevent desaturation, which means a drop in oxygen levels. That's obviously a non-delegable skill. Crucially, this intervention involves deep suctioning, which is explicitly noted as not in the high-intensity support worker skill descriptor. Support workers or general registered nurses are unable to safely perform this intervention as it places the individual at high risk of hypoxia, airway trauma, and the introduction of pathogens. Only a critical care registered nurse can provide the continuous monitoring essential for airway protection, conducting lung auscultation with a stethoscope and also the essential interpretation of such, and implementing time-sensitive interventions like nebulizers, chest physiotherapy, but also then BiPAP to prevent life-threatening complications. Also, for deep suctioning, most of the time you need a nasopharyngeal airway or a Guedel airway. And again, these are essential CCRN nursing skills, not even general registered nursing skills. Further evidence-based guidelines on managing complex respiratory needs at home refer to the evidence-based clinical framework on the mechanical home ventilation guidelines on our website at intensivecareathome.com. Next, refractory epilepsy and SUDEP risk. The client suffers from drug-resistant refractory epilepsy, experiencing multiple 10 to 20 plus atonic seizures daily, with tonic-clonic seizures occurring approximately every 1 to 4 weeks. That requires very complex medication management. Tonic seizures can rapidly escalate to tonic-clonic seizures if the stimulus is not removed and managed, often requiring enteral clobazam to negate deterioration. Tonic-clonic seizures require immediate intranasal midazolam and titrated oxygen administration. CCRN management is required for the complexity of medication administration and escalation of care, including the difficult task of titrating oxygen to prevent over-oxygenation from worsening her hypercapnic respiratory failure. Next, mortality risk. The risk of sudden unexpected death in epilepsy, also known as SUDEP, is often correlated to unwitnessed nocturnal seizures, where rescue medication is not administered. Due to insufficient funding constraints, the client is currently not continuously monitored overnight, and that's an unacceptable and high-risk situation. Acute physical deterioration and comorbidity risk. The client's dystonic quadriplegic cerebral palsy is compounded by secondary conditions like scoliosis, osteopenia, and hypercalcemia. This places the client at significant risk of painful fractures with minimal trauma and chronic pain associated with immobility. The severity of the client's disability and nonverbal status also means that the client requires prompt and astute attentiveness to the subtle idiosyncrasies. General registered nurses or disability support workers are simply not well enough equipped to interpret and appropriately respond to limited communication as critical care registered nurses are, as they are, used to communicating with patients in intensive care that are nonverbal. Due to the complex nature of the comorbidities and history of poor outcomes, generally speaking, for those clients, a CCRN is required 24/7 to detect early signs of physical deterioration, perform frequent head-to-toe assessments, often hourly in some periods, and provide timely clinical intervention. While disability support workers can recognize visible skin issues, they're not qualified to initiate clinical interventions that prevent further deterioration, such as complex wound care or preventative measures against pressure injuries. In summary, the time-sensitive and complex nature of the client's disability that leads to the health issues, including the high aspiration risk, BIPAP use, medication management, which involves administering or withholding based on comprehensive health assessments, and constant vital signs monitoring, mandates 24/7 care from critical care registered nurses. It's not a matter of convenience, it's a matter of life or death. Now, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care, tracheostomy care for clients without ventilation, home care services for patients on non-invasive ventilation such as home BiPAP, home CPAP, home TPN, which is also known as IV nutrition, home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We are providing central line management, peak line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home, the use of cough assist machines for our clients for airway clearance at home, palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%, An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day, and we're freeing up the most sought-after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families and by a team of dedicated intensive care nurses in the home care setting instead of in an intensive care unit. With intensive care at home, we are currently operating all around Australia in all major capital cities as well as in all regional and rural areas. We work with NDIS clients all around Australia, TAC and WorkSafe in Victoria, Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are having policies and procedures for intensive care at home nursing, and we've built all the intellectual property for intensive care at home since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. So if you're at home already and if you're watching this, or you're stuck in an ICU long-term, or if you're going to hospital and ED all the time and you realize that you don't have the right level of support at home, or if you are stuck in an ICU, I'll give you a real-world example today how we can help you. One of our first clients when we first got started in 2012 was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a client at home on a ventilator with a tracheostomy. That is dangerous and it's simply negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with the cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying if they don't have a team of dedicated critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So this client at the time found out about us eventually, and the ICU that he was basically living in also knew about us and eventually reached out to us. And we were proving our concept with this client very fast. When we worked with this particular client, we sent him critical care nurses 24 hours a day, and he never ever went back into ICU ever again, as long as we were working with this client. We can do the same for you if you're not safe at home and help you with keeping you at home predictably. Otherwise, we would not be in business. Again, the same is applicable for those stuck in an ICU, similar to this case study that I've just given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. If you're an NDIS support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you need more evidence for nursing care, we are also writing NDIS nursing assessments with legal nurse, critical care consulting nurses. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. You can join this high-performing team if you are a critical care nurse. If you are looking for a career change as a critical care nurse, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, in Warragul, in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building solid relationships with us and with our clients. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or for home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US and in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.